The next topic is spleen. Spleen, as we all know, is the largest lymphoid organ. And it acts as a blood reservoir and it stores up to 2% of the blood. Normal weight of spleen is around 75 to 100 grams, and normally it is not palpable. So the spleen becomes palpable only when it enlarges in size up to 2.5 of its normal size. Then it becomes palpable. When enlarges to more than equal to 2.5 times of its size. Okay. Now, origin of spleen, MCQ, it arises from it arises from the cranial portion or the cephalic part of dorsal mesogastrium. So spleen arises from dorsal mesogastrium or from the cephalic part of the dorsal mesogastrium. Okay, and the long axis of spleen is along 9th, 10th, 11th rib. Okay. Now, what regarding the arterial supply, the splenic artery is a branch of celiac axis. Okay, which is a direct anterior branch of aorta. So from aorta arises celiac axis anteriorly, and the celiac axis then divides into three branches. Three branches are the left gastric artery, splenic artery, and the common hepatic artery. Okay, so splenic artery is the branch of celiac axis, and splenic vein arises from the spleen, and then it goes behind the pancreas. It joins the SMV behind the neck of pancreas and makes portal vein. Okay, so the splenic vein joins SMV behind neck of pancreas to form portal vein. Okay, this is very important. Splenic artery is a branch of celiac axis, and splenic vein joins SMV behind neck of pancreas to form portal vein. Okay, and arises from cephalic part of dorsal mesogastrium. Okay, now some important questions regarding spleen. First, we'll go for splenic cyst. So, what is the most common type of splenic cyst overall? Overall, if we'll see, the most common type of splenic cyst is actually a pseudocyst, which is seen in 70% cases. Okay, 70 to 80% cases. Now, this pseudocyst is not the actual cyst. Then what is the most common true cyst of the spleen? It is hydatid cyst. Okay, so hydatid cyst. Overall, most common type of splenic cyst is pseudocyst. Most common type of true cyst is hydatid cyst, and most common congenital splenic cyst is epidermoid cyst. These two are from previous questions. Now, regarding the tumors, okay, what is the most common neoplasm of spleen? Okay, most commonly spleen is part of non-Hodgkin's lymphoma. Okay, so most common neoplasm of spleen is non-Hodgkin's lymphoma. Okay, but if we'll talk only about the spleen, then what is the most common primary benign tumor of the spleen? It is hemangioma, and most common primary malignant tumor of the spleen, it is angiosarcoma. Okay, these are previous year questions only. Most common neoplasm of spleen overall is non-Hodgkin's lymphoma, but what they are more interested in asking is most common primary benign tumor. Okay, primary benign tumor is hemangioma, primary malignant tumor is angiosarcoma. Okay, now there are metastasis to spleen also, which is actually rare, but if we are talking about spleen, then if there are metastasis to multiple places, along with these multiple places, spleen is also involved. In that case, the most common tumor which is metastasizing to spleen is malignant melanoma. And if we are talking about isolated splenic secondaries, then the most common tumor is carcinoma ovary. Okay, this is very important. The most common primary tumor for metastasis to spleen is actually a malignant melanoma. But when we are talking about the primary for isolated secondaries, this isolated word is very important. Isolated secondaries to spleen, it is CA ovary. Okay, so this is important. Now, the next topic is splenic abscess. Okay, so for splenic abscess, this we will have to understand. Splenic abscess can be single or multiple. Generally, in a healthy patient, splenic abscess is unilocular. In immunocompromised patient, they have a multilocular abscess. Okay, so splenic abscess in healthy patients is generally unilocular, and in immunocompromised patients, it is multilocular. The problem with uh, immunocompromised patients and a multilocular abscess is that it is associated with poor prognosis, and the mortality is in the range of 70 to 80% because the patient is immunocompromised and there is multilocular abscess. And when we talk about this healthy and unilocular abscess, the mortality is in the range of 15 to 20%. Overall, if we are seeing splenic abscess, the mortality rate is high. The most common organism which is responsible for splenic abscess is Staph aureus, and this fungal abscess is associated with candida infection and seen in immunocompromised patients. Okay, now most common is Staph aureus. Now, what is the etiology of splenic abscess? The etiology is due to any malignancy, polycythemia vera, some malignancy, polycythemia vera, IV drug abuser, HIV positive patient, some hemoglobinopathies, or presence of UTI. These are the causes of splenic abscess. Now, there is the presence of splenic abscess. The patient will present with abdominal pain. On clinical examination, there is tenderness, patient is having fever, peritonitis, and there is left-sided pleural effusion or pleuritic chest pain. When patient is taking respiration, the diaphragm will hit the spleen and there will be pain. Okay, so the clinical features are abdominal pain, abdominal tenderness, then there is fever, pleuritic chest pain, left pleural effusion. Okay, now we have a clinical exam suspicion of splenic abscess. What is the initial investigation of choice? Initial investigation is ultrasound of the abdomen. And what is the investigation of choice? It is CECT abdomen. Okay, now on CT we will be able to identify that there is a splenic abscess. If there is a unilocular splenic abscess, we can aspirate the abscess. Along with that, we can give the antibiotics. If there is a multilocular abscess, we'll have to go ahead with a splenectomy, because multiple aspirations from multiple places is not possible, and along with that, we'll go for antibiotics. This is regarding splenic abscess. Now, next we are going to discuss ITP. ITP is now called as immune thrombocytopenic purpura. Okay, so it is associated with autoantibodies, and there is presence of thrombocytopenia, that is decrease in platelet count, and there is presence of purpura. Okay, now what happens here is that autoantibodies they are attached to the platelets. These platelets are then destroyed in the spleen. Okay, then the platelets are destroyed in the spleen, and ultimately there will be thrombocytopenia and there will be petechiae, ecchymosis, purpura. Okay, so then there will be decreased platelet count and there will be ecchymosis, purpura, petechiae, etc. Now, chronic ITP is generally seen in girls, and patient generally presents with petechiae and purpura. Okay, chronic ITP is generally seen in girls, and this acute ITP is seen in equal in male and female. Okay, the clinical features are there is presence of petechiae and purpura. Because of thrombocytopenia, there is presence of epistaxis also. Sometimes there is menorrhagia, and spleen is characteristically normal in size. Okay, so spleen size is normal. Okay, now as it is an autoimmune disorder, what is the treatment here? The treatment here is steroids, azathioprine and cyclophosphamide. If the patient is not responding to the management, okay, or what is the gold standard treatment, then we will go for a laparoscopic splenectomy. Why we are going for laparoscopic splenectomy here? Because the size of the spleen is normal. Okay, so we can go ahead with a laparoscopic splenectomy here, and this is the gold standard treatment here. Okay, so we'll go for laparoscopic splenectomy in chronic ITP. Now, in splenectomy, can we go for a splenectomy here if the patient is having a platelet count or a low platelet count? Okay, so in ITP, we can proceed with splenectomy if platelet counts are more than 50,000. Normally in other surgeries, we take platelet count of more than 1 lakh, but in chronic ITP or in ITP, we can take the patient for surgery if the platelet count is more than 50,000. Okay, and during surgery, we want to transfuse platelets. Okay, but if we have not ligated the splenic artery or splenic vein, then at that time, can we give platelet or not? Okay, so there is a question which is repeatedly asked many years, that when we will transfuse the platelet. During splenectomy. Okay, so we don't want the platelet to go into the spleen now, because spleen is destroying the platelet. So blood is going into the spleen via splenic artery. So we will be giving platelets only after the ligation of splenic artery. Okay. So we will give transfusion of the platelets after ligation of splenic artery. Okay, so this is actually the most important line in whole of the chapter. If you will see, the spleen will give transfusion of the platelets after ligation of the splenic artery. Okay, this is very important. Now we have done a splenectomy. So after splenectomy, what is the most common complication? Or after splenectomy, patient is having fever on post-op day 1, 100 degree Fahrenheit. The diagnosis is, the answer to this question is atelectasis. Okay, so the correct answer is atelectasis. Sepsis does not occur within 1 year. Abscess and collections does not occur in 1 day. Okay, so for that to happen, at least 3 to 4 days time it will take. So if the patient is developing fever within first or second day, the correct answer is atelectasis. Anyways, after splenectomy, the most common complication is atelectasis. So they'll give you the question like that: a patient with chronic ITP underwent splenectomy. After splenectomy, the patient is developing fever from on first post-operative day. So the correct answer is atelectasis. We should get a chest X-ray done and we should see what is the probable diagnosis. Okay. Now, overall, if we'll see what is the most common indication for splenectomy overall. Okay. So here I am talking about overall. So the correct answer to this is trauma. Okay, spleen is the most common organ involved in blunt trauma injury to the abdomen. Spleen is most common organ injured in blunt trauma abdomen. Okay. So overall splenectomy is done in trauma most commonly. And most common indication of elective splenectomy is ITP. Okay. Now other points. Splenectomy is always indicated in primary splenic tumor. If there is a primary splenic tumor, most common primary benign splenic tumor, hemangioma, most common primary malignant splenic tumor, angiosarcoma. And another point is splenectomy is always indicated in hereditary spherocytosis. Okay. Now, it is these 2 points, that is splenic malignancy or hematological malignancies, they are high risk candidates for OPSI. Okay, I'll discuss OPSI later on, but you'll have to remember the point that splenectomy for a primary splenic tumor or splenectomy for a malignancy, you can say, and splenectomy for a hematological disorder. These both patients are the patients who are at high risk for development of OPSI after splenectomy. Okay, now the other indications for splenectomy are primary hypersplenism, chronic ITP, splenic vein thrombosis. Why in splenic vein thrombosis? Because there is development of portal hypertension, or we can say that left-sided portal hypertension, and the treatment for that is, or the treatment of choice is splenectomy. And another point is splenic abscess. Generally in multilocular splenic abscesses, we are going ahead with the splenectomy. Okay, now after splenectomy, there can be various complications. I'll first draw a diagram of the abdomen. So there is a spleen here. Spleen is in close relation to the tail of the pancreas and to the diaphragm, and then above it there is left lung. Okay. So generally there is subdiaphragmatic collections, or abscess. There is injury to tail of pancreas, or overall if you'll see the most common overall complication is pulmonary, and the most common is atelectasis. In atelectasis there is fever within 48 hours. Generally it is not associated with chills and rigors because it is non-septic, not associated with chills. Okay, so this is atelectasis. How we can manage? We will ask the patient to do spirometry, okay, or breathing exercises. Then there can be a subdiaphragmatic collection or subdiaphragmatic hematoma, or during splenectomy there can be injury to the tail of pancreas, okay, so which can lead to development of a pancreatic fistula or pancreatitis. Then after splenectomy, there is a rise in platelet count. So this rise in platelet count or thrombocytosis can lead to thrombosis, or you can say DVT. Okay. Now, what is the most common fatal late complication of splenectomy? Or what is the most common late complication of splenectomy, which is actually very fatal? So the correct answer to this is OPSI. Now, what is the full form of OPSI? It is very difficult question because it is very difficult to remember. It is overwhelming. We are reading lot of things about spleen, but they'll ask only what is the full form of OPSI. Then also 30% of the student will mark it wrong. Okay, so this is very important to remember. It is overwhelming post-splenectomy infection. Okay, so it is overwhelming post-splenectomy infection. So this infection is occurring after splenectomy, and the response is very rapid and very severe, overwhelming. Okay, so why it is overwhelming? Because mortality is 40 to 50%. Okay, so and after how much time after splenectomy this is occurring? This is occurring after 2 to 5 years of splenectomy. Okay, this 2 to 5 years has been asked. So majority of the cases occur within 2 years or after 2 to 5 years. So generally they occur in between 2 to 5 years of splenectomy. Okay, so it is less in trauma patients or splenectomy due to trauma, and more in patients in which splenectomy is done for hematological disorders or malignancy. Okay, mortality is 40 to 50%. Now, what all are the organisms responsible for OPSI? So the organisms responsible are, the way I have remembered is simple: pneumococcus, meningococcus, and Haemophilus influenza type B. Okay, so actually it is Streptococcus pneumonia, okay, which is the most common organism. This is also known as pneumococcus. It is the most common organism responsible. Then there is Neisseria meningitidis, and then there is Haemophilus influenza type B. Nowadays, that long-standing splenectomy card is not being given, and the patient will carry that card lifelong. They will give them antibiotics for long to prevent OPSI. That is generally not done. We are focusing more on prevention of OPSI. Okay, prevention of OPSI is possible by giving vaccine. Okay, so we have vaccine for pneumococcus, meningococcus as well as for Haemophilus influenza also. So we give these vaccines to the patient. Generally, we prefer it before elective splenectomy. We give it before 2 to 3 weeks before surgery, and in cases of trauma, immediately after surgery. Whenever it is feasible on the next day of surgery, also we can give. So, best time for vaccine is at least 2 weeks before 2 weeks before elective splenectomy, and in cases of trauma or emergency as early as possible after emergency splenectomy. Okay, so that is all about spleen.